from Stanford and Sumit Sharma from Hull as well. Dr. Ehsan Rahimi will be joining us shortly. Today's theme is, wow, I never knew I could do that, which is probably what you all feel as first year fellows, getting thrown into challenging cases, maybe even straightforward cases, but it's our first time kind of sitting at the head and doing the delicate parts of these cases. So these cases aren't meant to show like perfection. It's meant to show process as you're going through it. So our job is to kind of watch what you're doing, walk you through our thoughts and what we've learned along the way. So you may never get through your entire case uninterrupted, just warning you as we go. So let's toss it over to the Cole folks to start. Neil?
Sounds good. And by the way, this is something Prithvi says every day when he operates. I can't believe I get to do this. We weren't sure he was going to make it as a fellow.
Am I allowed
Uh,
to be here?
this is true. We still haven't seen that
Yeah,
certificate.
that's
Starting with our first year fellow, Matthew Regario. Matt comes to us trained here at Cole. He did his undergrad at Franklin and Marshall in Pennsylvania, I believe, and then medical school at Emory. And now here with us as one of our first year fellows. Matt, take it away and show us your case.
Sounds good. Thanks for having me. I'll share my screen.
Very excited for Matt to show how well the Cole people know how to use technology. Take it away, Matt.
Can you
We're
see my
winning
screen?
already.
Yeah.
All right. Okay, so this is, I guess before I get started, this is a case I did, one of my first cases I did with Dr. Downs, a former Cole fellow who's now faculty here at Cole.
An alum of Cobra also,
That's
which is
right.
very
She
exciting.
survived.
A
He
Cobra alum.
survived.
This was a case we did over at Metro at the county hospital in Cleveland in July. So as you can see there, 64-year-old guy coming in for a worsening ERM in the left eye. Pretty unremarkable history otherwise. You can see the OCT of the right and left eye. Left eye was 2200 pre-op. Hyaloid, you can appreciate the posterior hyaloid obviously in this OCT as well.
So Neil, this is one I inherited from you, so you can see if you can tell the patient by the eye.
I'm sure I left her in great hands. Him, them, this
Hey,
person.
Matt, any pre-op considerations? You can pause here, like you're taking an eye in 2200, like this has been this, what's the duration and any other etiologies you're worried about? Is this just idiopathic? And what phase of the angiogram did you enjoy the most in reviewing in this patient?
This is chronic. It had been slowly worsening over time. As Dr. Downs said, this was actually a Dr. Srivastava patient for a while. And he had actually been hoping patient to get a peel for a while. And because of some factors I hope you might be able to appreciate on the video, Dr. Srivastava actually kind of wanted to wait a bit just because some things that hopefully will come through on the video you'll see is a little atypical. But besides, what we'll talk about, he had a little bit of lattice, which kind of impacted how we'll do our hyaloid lift. But otherwise, a pretty unremarkable history. Obviously, Dr. Downs, feel free to correct me if there's anything I'm missing, but pretty unremarkable history. And one of our wonderful residents did the phaco, put a 3-piece lens in the bag, and now we're starting the vitrectomy. So did a Corvette, cleared the ports, stained here with
Is this
Kenalog.
dilute trilucence or is it
Yeah,
full strength?
Straight up.
Sorry, yeah.
So Matt, walk us through what you're thinking here as you're lifting.
Yeah, so obviously we saw in the pre-op OCT, which I think is very helpful. Hyaloid was still down, so we knew that before starting with the peel, we would want to lift hyaloid and then do the vitrectomy. This was one of my first hyaloid lifts. I think the name of the game is really keeping your cutter very close to the nerve initially, and I can pause while we talk, I guess. But, obviously cutter off, high vacuum, close to the nerve.
So happy
Um,
with this lens. So it's a great
and
option.
basically maintaining high level of aspiration and stay at the nerve for a while until you really fill your cutter port with vitreous. And then kind of slowly walk your way out in different directions as I was, trying to show here. It didn't come up as one, beautiful lift. Obviously, it had to take a few efforts in different directions there, but eventually got it all up.
Hey, so Matt, walk us through also what's the most surprising as you're doing this? You're obviously a successful anterior segment surgeon. I'm sure you were happy to watch your former resident, your co-resident do the phaco. You're probably licking your chops doing it. Give me the idea difference for you when you're doing this, one of these first ones bimanually, like with what you're working through.
It sounds obvious, but the complexity of, having to pay attention to what all four of your limbs are doing at the same time. Obviously, the elephant in the room, you're obviously focusing on the cutter port, with your right hand, but then simultaneously keeping your left hand in a reasonable location where you're able to, light probably ideally better than I'm lighting right here. But, maintaining a decent level of lighting with your left hand and then zooming out a little bit with your right foot, while maintaining full aspiration with your left foot until you get far enough out to flip on back on to cutter on. It's kind of that, trying to have all four, both hands, both feet, and then your eyes kind of moving between, where your cutter is and then also where you're lifting the hyaloid, making sure the retina's down. It's kind of all of that going on at once is what you appreciate insofar as people tell you that it'll be hard and then you do it and you're very actively thinking about what all of those different, hands and feet and eyes and brain are doing at the same time.
Nice,
Hey,
nice start.
Sumit
Good going.
Sharma, I had a question for Sumit. Are you looking at which hand you're bringing in to do the lifting? Like if it's left hand, are you starting with the cutter in the left or right? And do you often find that you have to switch hands in between one of these maneuvers on a given case? Let's say it's a little bit more challenging to get the hyaloid up. Any
I think
thoughts?
in most of these cases, especially with first year fellows, I have them use their dominant hand for the cutter and keep the light pipe in their non-dominant hand. I think usually you can lift the hyaloid with your dominant hand and you don't need to switch. There are some weird cases, super adherent hyaloid, where you have to where you may need to switch hands, but that's not common. Usually I'm telling first year fellows, stick with your dominant hand, get good lighting, get the view centered, zoom in, make sure everything is focused and then start to come down with your cutter. And you really want to take it slower than you think when you're first starting out.
And then, Carolyn, in like first case like this, how far out do you have the fellow take the hyaloid out? Like here, it looks like we're going pretty far equator and maybe a little anterior to it. But what's your like general like thought on a case? Are you going far peripheral, or are you good with this?
I have them lift up to the equator. This one was a little unique in that it seemed to kind of lift in each quadrant individually, irrespective. It wasn't like a ring. But oftentimes when you do see that ring, I have them go to the equator and not further because they're looking again where the cutter port is. I'm looking everywhere, but they may not notice that they might be pulling or like exhibiting traction on some peripheral part of the retina. And so just for good habits, I have them go up to the equator and then they can kind of extend as they're doing their peripheral shave later.
And that actually dovetails nicely into this video. And I'm not sure that it showed up very well, but this patient, as you'll see later in the video, had some inferior lattice that Dr. Downs wanted me to be cautious of, lifting through. So we stopped there and then kind of shaved down, as you'll see later in the video, inferiorly.
I gotta say, good lighting so far. I mean, this is some of the hardest thing to do but your lighting is pretty good.
Thank you. And we're going through vitrectomy now, and then this is the area as you can see here with the kind of lattice inferiorly there that we were shaving down. Kind of working around 360 on the vitrectomy here. Obviously, I fast forwarded through many different parts of this case.
And Matt, is this your non-dominant hand you're doing now?
This is yeah, and then there's a yes. So this is left hand here, and there will be a
Nice.
part further forward where Dr. Downs takes over for a moment. She actually this flex loop here, Dr. Downs initiated the flap, and then I took it from there. So I can't take credit for this beautiful flex loop maneuver.
So, Matt, why don't you pause here?
Yeah.
What lens are you using now? Like, what did you do? What did you change here? What is your plan? The flex loop initiation is good. Are you going to now show us propagation with the flex loop? Are you going to go to a tonneau scraper? Are you going to try to grab it? And what's your goal here? Are you looking for a wide peel? Like, just kind of tell us what you were thinking before you started, and then you'll show us
Yeah.
what you did. But help us a little bit.
Yeah, absolutely. Dr. Downs, feel free to correct me if anything I say is incorrect or I'm leaving out any details.
Oh, don't worry, she will.
We had switched, so we were on the resight. We switched to the green lens here to get a better view of the posterior pole. And then obviously stains with ICG. And then Dr. Downs is using the flex loop here. And one thing I learned pretty earlier on is you can titrate how far out the loop is for how much, flexibility you want and how, gentle you want to be with the retina. So the flex loop is pretty far out here. So it's very gentle. And generally you're looking for kind of broad strokes, and you kind of want to make, ideally, you'd like to make one large flap that, in an ideal world, you can bring that, propagate one large flap and bring it, through the fovea without it kind of shearing or splitting right at the fovea. Yeah.
Yeah.
And in this case, the plan, because this was my first one, Dr. Downs was making the flap. She could have certainly propagated it, or we could have used the Tano, as you said, but she kind of just made the flap, and then we switched to shark skins in a moment. And I left a lot, as you'll see here, we're about to switch and I'm about to take over. This is me. I actually fast forwarded through a lot, but I wanted to show, for my very first cases, it wasn't like the, most straightforward or, classic peel you see. There's a lot of attempting to grab, and then eventually I'll slow down a video where I'm actually, able to successfully purchase some of the ILM here. And then you'll see it fast forward again when I try to regrasp at a different area.
So, Matt, the other thing that's happening here, and you can pause, is that, you have ILM, but there's ERM on top.
Exactly.
Tell us a little bit about your tactile, feelings when you're doing this, because it may be that you're trying to grab, but something is like, either bouncing back, or did it feel elastic to you? And like, were there areas that were easier than others?
Yes. So this is certainly one of those cases where it's a combo of ILM and epiretinal membrane. And there were areas through here, as you'll see when I'm trying to, propagate this, that felt like they were more adherent to the retina. There's a little bit more, there were areas that felt a little more elastic and areas that felt a little more taut. And actually, this is a good clip. You can kind of see on the inferior retina here. And this is one thing Dr. Srivastava had noted for a while. He was following this patient for a while. And, ultimately we didn't have a name, or we didn't really call this anything in particular, but it didn't look, those little kind of white punctate areas in the inferior retina, or sorry, rather superior retina, just didn't look like this, like the epiretinal membrane, or was the only pathology here. And to your point, yeah, there were certainly areas within the macula that felt a little more adherent than others, and which is why, if I felt like there was too much traction, there were times where Dr. Downs, instructed me to maybe let go, try to regrasp, don't, tent up the retina, especially the posterior pole, and obviously try to be as gentle as possible on your first attempt at doing this.
So Matt, you kind of alluded to this like superior whitish stuff. Maybe there's other pathology going on. To the faculty, like how extensive a workup do you do for ERM patients before you take them to surgery for a membrane peel?
So for this gentleman, I inherited him in the in the fall. So, you'd been pulling for a couple years and had talked to him about membrane peeling in the past. The ERM was a little bit more mild, and you saw that area of pigment inferiorly, which looked chronic. I think you thought maybe he had had some sort of uveitic process in the past, but that we hadn't seen any activity since we'd been following him. But I still got an FA back in February because, to Kat's point in the chat, I felt like the vision was a little out of proportion to the severity of the ERM. It was clean, normal, nothing of note on there. So that was in February. Then I went out on leave and I said, we'll revisit this when I come back. And he was like gung ho. The ERM continued to progress. So we went for it. But I didn't do anything beyond the FA and multiple ophthalmic imaging.
So I don't, I think I should be getting more FAs than I do on these cases because I used to pretty regularly. I think if, again, the membrane is in alignment with what I think the vision is, and I don't see any other, obvious lesions, then I probably wouldn't get an FA. But often I think I regret sometimes not getting FAs, especially when vision doesn't improve. Maybe there was an occult vein occlusion or something, but I should probably do more than that.
I think a good depressed exam on someone who has lattice as well, because that's often the cause. And my hint to most fellows is in ERM, you got to make sure, you got to prove to me there isn't a break, there isn't a peripheral pathology. If I remember this person correctly, I just was always suspicious of something, and just with the pigmentary changes, and couldn't prove it. The fact that he was quiet for years, I think, made me feel better. But anyone who you think may have an inflammatory process is probably worthy of getting a fluorescein just to make sure you're not missing something else, because then you can set expectations with regards to vision as time goes on.
So this is a question both to Matt and to Rachel. So you were coming close to the fovea with your peel. So Matt, what were you doing anything different? What were you thinking? Where were your eyes kind of focusing? And Rachel, from the side scope, what was your point of view as to what was going on? So Matt, you go first.
What the hell is Rachel thinking here? That's what I want.
I'd love to say that I was looking everywhere, but for this first one, I was looking just at basically my forceps, making sure I wasn't going, too deep, especially as we were going near and adjacent to the fovea. I really obviously just didn't want to touch down. In an ideal world, my eyes would have been kind of saccading back to, where we were peeling and to my forceps, but I'm pretty sure I was mainly focused at the tip of my forceps, to be honest.
Yeah, I think that I was thinking back to my first peels as a fellow, which was not too long ago, and all the nervousness that I was feeling at that time, and trying to remember that Matt might be going through that too. And I remember John Sears gave me the advice on one of my early peels when I was clearly nervous and getting a little bit frustrated that the ARM is going to come out before we leave the OR. Don't worry about that. Don't get frustrated. I think that half the battle with retina surgery, maybe more than half, is your mind and keeping that in check. So I just was trying to. Matt didn't get frustrated. He did a wonderful job, but just try to keep encouraging him that if it falls back, it's okay. You'll go get it again. It's normal.
Show us what you got, Matt.
And you can see through all this fast forwarding that Dr. Downs was quite patient with me. One other thing, I won't pause this, but I do think it's interesting, and I think maybe to some extent I was accommodating through it, but there were a couple times where I think I was nervous enough. I was holding my instruments pretty tight and was kind of slightly pushing the whole eye away from me. And you can kind of tell that the view was going slightly in and out of focus when you rewatch the video here. So we were clearing, I think it was on this one, maybe the next one. Yeah, so that one almost cleared through the fovea, but kind of split right above the fovea. And then fast forward through all of these additional attempts at picking up what, I think especially temporally was a combination of ILM, ERM. And I think it was this one. We finally kind of got that temporal macula, fovea, superior retina clear.
That's a great peel. Nice
That's
job.
Looking nice.
That's great. What a great feeling.
The right spot.
Yeah,
the perfect spot.
Rachel is breathing now. That's a good sign.
Clearing out some of the bubbles anteriorly, and then just kind of finishing it off. It's still obviously left behind those little pigmented lesions that Dr. Downs was mentioning earlier.
As you're going through this, I'd just say, as a young attending on the other side, it's okay to switch. I always say that it's all right. You'll have plenty of opportunities, and most fellows are just excited about the opportunity. So, this is great patience. Nice job, Rachel.
And then we finished the vitrectomy, and then I think Dr. Downs at the very end takes over to just laser this lattice inferiorly. We shaved a little bit closer to some of that vit that we left behind, like right over the lattice. And I think this was Dr. Downs here, and then she applied some laser around this area. And then I think we have the post-op OCT at the end here. So vision post-op week 1 is identical.
Actually, no, Matt, he pinholed to 2070.
Oh, nice. All right. I take it back. Pinhole to 2070. And it looks a lot better. That makes sense. I was wondering why he didn't get any better with that looking like that. So thank you, Dr. Downs. I appreciate the case.
It's 1 week, y'all. Come on. No one refracts or anything.
Improvements.
That's all I
Nice
got.
job. What a great start.
Nice. Yep.
What a great start. That's I think early on there's just this desire to like peel, but I'm going to tell you, Matt, some of the best work you did was just hyaloid lift, right? Hyaloid lift,
Mhm.
illumination. Even though you're in and out of focus, those are the things to kind of take home. So great job on
I
all
think
sides.
the getting the membrane off was great. Like it was like a
Yeah.
perfectly like controlled movement. That's awesome.
Yeah. That's
Good job.
great. A lot of good things to take home, but it's okay to retry and regrab. But you do have to get going at some point in time, which means Prithvi, time for you guys.
Thank you.
Introducing Eleanor Burton. Ellie joined us from the East Coast. She went to Hopkins for medical school and University of Virginia for her residency, and has done a fantastic job and has been stuck with me on her first rotation. We all feel sorry for her, but Ellie's going to show us a challenging case and how she tackled it. Ellie.
All right. So I'm going to talk about a case that I did with Dr. Muthanjaya a couple weeks ago. So this was a 67-year-old male with stage 4 diffuse large B-cell lymphoma of the bone marrow who developed blurry vision in his right eye about 1 month following completion of his chemotherapy. On his initial examination, he was light perception, normal pressures, had a positive RAPD in that right eye. This was his initial exam in our office. You can appreciate some mild vitritis, diffuse retinal whitening. The initial concern was highest for an infectious etiology, and he was initiated on intravitreal ganciclovir and Voscarnet, initially Valtrex, which was discontinued due to intolerance, and PO ganciclovir. The whole kind of very large workup came back unrevealing, and unfortunately, he continued to worsen, and you can see the worsening vitritis and spread of the retinal necrosis and obliteration of the vessels. On OCT, we appreciate some pre-retinal membranes, really some subretinal infiltration here, no clear PVD. So there was a lot of pre-op planning going into the decision to do a vitreous biopsy. Our plan, our hope going in was to do biopsy of the vitreous, subretinal tissue, and a full thickness retinal biopsy. And so we literally drew this table out on our whiteboard in the OR so that all the OR staff and everyone knew. So the undilute vitreous was sent for cytology and cytolite. The MIDI 88 is just in fluid, and then the viral EDL serologies as well. And then the dilute vitreous for flow and RPMI. And so we'll go through. So just to kind of set the stage, this was our vitreous biopsy setup. This was an image not from our OR, but you basically connect a 10 cc syringe to the aspiration line for manual aspiration during the biopsy. And then for the subretinal biopsy, we use a nano subretinal gateway device. It's a 40 gauge, and we do use the curved needle so that when you deploy it, it comes out curved like this picture on the right. And this is hooked up to a 3 cc syringe for aspiration.
So by the time we got the patient to the OR, we saw him after those two initial pictures, and he was NLP by this time and confirmed. So this was an eye that didn't see, and there's no other source that's been identified. So oncology wasn't prepared to treat, even though we strongly recommended treatment. So we had to try to get an answer.
Yeah, that's right. Right, so getting started initially, you can see his pupil is pretty sneak down, so just going in with some Helon to do some sneaky lysis. And then we're going to use iris hooks here to help expand the pupil. We did talk about potentially removing the lens as well, but we felt that we could probably have a successful surgery without it. And so we did decide to proceed without taking the cataract in this case. And then we did just a focal peritomy for the superotemporal port in anticipation of potentially the full thickness retinal biopsy, which would require enlargement of the sclerotomy to remove the tissue. So cauterizing that there, and then you'll see here that I bevel maybe in retrospect would go straight in to remove the tissue more easily. So we're starting with undilute vitreous biopsy. So the cut rate was down to around 3,000, vacuum was off, and there's a lot of like start and stop focalizing. I'm going, and then Dr. Mruthyunjaya aspirating in those moments and targeting areas of cellular vitreous. And then we turned on the infusion once that sample was collected. And again, a lot of communication going around targeting areas of vitreous that looked the most cellular and communicating when to aspirate as I was cutting. And
Hey, Ellie, let me pause you for a second. So let me ask Sumit, because he does a fair number of these. What do you think about doing undiluted and such? Do you still do it? Or how do you do these?
Yeah, so I stopped when one of the pathologists asked me why we send them a undiluted sample when they just spin it down, and why would you put the eye at risk? So I stopped doing that. At least at our institution, they combine the two samples, spin them down, and then look at them all together. And so I've completely stopped doing the undiluted. I think that you put the eye at a significant amount of risk, and if you're not careful, you can get choroidals. Had that happen. You can get bleeding. I've had that happen, and since I've stopped doing it, I think it's a much safer way. They're going to spin it down, pellet it, and then take the cells out anyways. So that's why I stopped. I'm
Do,
curious,
do
Prithvi, are
you
you still do they do that or at your institution? Have you talked to them?
Yeah,
Are you still doing it?
yeah, so I still collect it as undilute and dilute, but I used to send them separately, like to cytology, dilute and undilute, and I think I kind of expected I'd get two reports back, but now that they kind of combined them, I still will just I'll just send it, and though we label it dilute or undilute, I know that I put my undilute initial specimen for things that I feel like you're going to need that yield. So for cytology and for MYD88 or like viral etiologies, I'll send the undilute, and then I'll send the bulk of the dilute vitreous for flow. But I've stopped like telling them to like report them separately. But your point's well taken. And I guess the other question to you is, do you do this under air at all, or in what settings will you use an air infusion to get your specimen, Sumit?
I've not done that. I'm curious when you do.
I mean, I've done
Why would you make a hard surgery harder
Yeah.
well.
by doing
Actually,
it under air?
yeah. So actually, you get like a lot of yield actually. So I'll do it in a pseudophakic case. I haven't done it in a phakic case because I'm just worried about what happens to the view. But if you infuse air in, the eye is maintained, and you can get yourself under the air meniscus and take yourself all the way down. And I think sometimes where that's helpful is that the cells aren't, sometimes you have cells that are, mid-vitreous, but sometimes it can be closer to the surface. And I think you can get at that. But you do need a good view. And I feel safer doing that with in a pseudophakic eye. This was not the right eye to do that in.
Yeah.
So
Keep going, Ellie. You're doing great so far.
Okay. So this is PVD induction attempt 1. So you can tell that the highlight's super, super sticky. There's just sheets that are very adherent to the retina. And so here, Dr. Mrityunjaya is telling me to just lift straight up because I kept wanting to pull towards myself, and the vitreous is more adherent over nasally there. So now just trying to kind of move nasally where the highlight wants to lift.
And the
So
view here is
Prithvi,
terrible. Like the cornea, like the lens isn't clear, which we didn't see pre-op, but it took him a little bit to get into the OR. And we also don't have this pink orange background as reference. It's all white. So it's
also
like very
Prithvi, on the
yeah
pre-op OCT, the retina was like basically necrotic. So like
yeah.
do you worry as you're pulling on this sticky hyaloid, like you're just taking everything with you, and like what's the
I
point?
don't worry
I
at
mean, it's
all. No, it was
patient's
terrible.
NLP, so
Yeah.
like
Well, I mean, this is on the chat. Why would you? I mean, do you even need to induce it?
yeah,
I mean,
that was yeah. That was my question to Ellie in my email.
Yeah,
Like,
I think
I still think
to
you
help.
do, but to get the layers, but it's
Yeah.
hard to do right now.
Yeah, but Sean asked a good question. Like, maybe it doesn't matter, but again, it's the question is like structurally, are you going to try to keep the eye in place, or not? So I think that's the questions. But I think we felt that we should try to get the hyaloid up if we were going to be taking the retinal biopsy.
Oh no, sorry. Yeah, so that'll come up in a bit, but yeah, our goal was to make getting the retinal biopsy easier by lifting the hyaloid. So I'll fast forward back to where we were. So we did end up staining with dilute triescents, and then managed to get up a little bit more of the hyaloid here, but still really didn't feel like we were fully successful.
Okay, Prithvi, do you have a concern with the triescence of causing some cell lysis and decreasing your yield? I try
Potentially,
to
I mean, we've
avoid it
taken.
in the vitreous biopsies when I have a concern for
Yeah,
lymphoma.
yeah, for sure. And then, we've already taken our specimens, thinking that that's going to be sufficient. So I think in the setting of a if we're going to do the full thickness biopsy, then um, I don't think it makes that much difference in the acute phase. I haven't found that it changes the outcome there.
Yeah, we also talked about, or one of my questions, is how much do you consider like when to stop pre-op steroids? And this patient wasn't on oral steroids, but was on topical steroids, which Dr. Muthanjaya, at least in our discussion, felt like wouldn't impact the yield enough to warrant stopping.
So I'll stop Durezol. Pred, I think I agree. I don't think it has that
Yeah,
much of an impact.
yeah.
I think you're going for a subretinal specimen outside of oral
Yeah, that's
steroids,
not
right?
gonna, yeah.
Yeah.
Mhm. So now we're going to the subretinal biopsy. So we ended up taking 3 different samples. This one is Dr. Muthanjaya. The view's pretty poor. The next sample you'll be able to see a little better, but basically you go in the eye, the device is not deployed. Once inside the eye, you use a little slider that deploys the needle fully so that it's curved, and then the goal is to try to go in kind of parallel to the retina. So you're going, here you can see me
This
going.
is Ellie poking the retina.
Yeah, super fun.
The view is definitely better. Nice job.
yeah, into the subretinal space there, and then pulling in the device before leaving the eye, and then we put the sample into this little Eppendorf tube in fluid.
So Ellie,
So we took out
why are you stopping the case now?
yeah, so we took out the iris hooks before doing fluid air exchange. Um, and the view stayed fine. So doing fluid air
So,
exchange and then going to do air to oil.
Christine, why not a full thickness
Oh yeah.
biopsy? I mean, why
Yeah,
not
that would
take
right.
a big piece? I mean,
Yep.
your NLP, uh, just take a giant do a giant
In
retinectomy here.
in retrospect, we should have. Our view was really not very good, and maybe you could argue that in an NLPI, like, does it really matter? But
Yeah,
I think we wanted to try to keep things
sure.
in, in somewhat of a location that, it wouldn't lead to disaster later. But in reality, even if we had a better view, like, I'm not sure what we were going to be lasering to, and there was
Right.
this, it was very infiltrated, but the view was just not in a position even to kind of just go for it. So we thought we had enough material, like, on with multiple bits of biopsy. Ellie, what did we find?
Yeah.
Oh
So
no.
I
sample
know.
unfortunately was undiagnostic.
Yeah. So you
Well,
going back in?
they found something. It wasn't lymphoma cells, which is what we thought it
what
should be.
what
So
would you
yeah.
find?
What do they find?
They just found some T cells. They weren't monoclonal. There were no B cells. Yeah.
So just
How about
inflammation,
wait,
and
hold on. But what
Hang
was the
on.
cytology? The cytology was negative?
it showed non lymphomatous cells. They weren't atypical cells. They got it. So we were able to capture cells, but none of them had any markers. The flow was negative, and I think the challenge here is, I think that there's so much, like, necrotic cells, because of the nature of what we're seeing there, that we just weren't able to get it. Whenever there's a negative yield on these biopsies, I'm always, like, blaming the pathologist. Like, it's not a me problem. It's a them problem. But sometimes, I just was hawking over these specimens, and we just didn't get the answer. So we're talking to the patient. He's because there's still this question of, like, what treatment he needs, not just for the eye, but if there's a systemic implication. The viral etiologies were negative again. And I'm not sure what other infection looks like this at this point. So we're talking about going back to take the lens and then get a large biopsy and leave him under oil. He's also considering enucleation because it's a blind eye and is starting to feel uncomfortable, which should hopefully give us the answer as well. So we're in discussions with the patient. It's pretty recent.
Wow, that's tough. That's tough. Couldn't you give Ellie like a straightforward case to start with, or
This was
like
this was day
like
one.
This was like the easier of our case.
Yeah, but I don't think we've done a diagnostic vitrectomy on Cobra before. So
oh, that was it. That's a
yeah.
great case. Oh, sorry, finish it up. Go for it. You're doing your fill.
Oh, that's okay. The rest is not exciting, but I did so this we did put in 1,000 Sunsoak oil and just thinking about looking for the reflux through the chimney and then tilting the eye here to get the air to float up towards that exit point was something we were thinking about. So that's pretty much it. And then closing.
Well, great job. But unfortunately, you get some negatives. This is part of it. It's usually the attending's fault. That's not the fellow's fault. When they're,
Fellow did
when they're
fellow
negative.
did awesome. Fellow did awesome.
I would have thought you would have gone big. So why the needle? I know we're going to move on, but why the needle as opposed to the vitrector? But you and I can
Yeah.
argue about that another time. Great
Yes,
case.
yes, we can argue about that another time. I thought there was just going to be enough material that would come out even with the 41, and I wanted Ellie to try the the nano gateway, which is a neat subretinal needle that extends.
Awesome job.
Okay.
Is this the bulk of the fellowship is just doing negative non-diagnostic vitrectomies? That's great.
Basically, yes. Vitrectomy to enucleation. That's usually what we're trying to teach our fellows, like, directly. So
You really need
it's
to know
actually
where
on
all
my
your limbs
service.
are, all your limbs are in that scenario.
Right.
Is that
Keep
the
it to the
plan,
side.
Prithvi?
So
Enucleation on this eye?
I think the patient's, it's complex, but he's thinking about it. If not, we'll go
Yeah.
back and then we'll
Hard
show that to
case.
you guys.
Very,
Yeah.
very
Hard
hard
one.
case.
That's
Yeah.
really tough.
Please show us something better, Cobra Eye Institute, please.
All
Anytime.
right. On to other things. Our next fellow, Adrian Delaney. Adrian went to my high school, alma mater, Bronx High School of Science. What's up, Queens, New York? Actually grew up not too far from where I grew up in Queens. And the better version of myself, she went to Harvard undergrad and University of Michigan, go blue, for medical school, and joined us for residency. And we're excited to keep her on with Matt as our fellow here at Cole. Adrian, take it away.
Thank you, and go science always. So can't believe I get to do this. My name's Adrian. I'm one of the first year fellows at Cole. So let's get started. Tech is still working. So our case, we have a 63-year-old phakic female. She is presenting with kind of an acute new symptoms out of her left eye. She's saying that she's noticing some distortion. It's been about a couple of weeks, and it feels like she's looking through a funhouse mirror in that eye. Her vision in that eye is 20/80. Here's a fundus photograph of that left eye. Media is clear, her optic nerve is good, and if you look over at her macula, you'll see that there's some distortion here that looks like she may have a macular hole. Looking through her OCT cuts, you see some vitreomacular traction here with some, outer retinal early hole and some schisis. But when you actually look through all of the cuts, she does have a full thickness macular hole, small with some vitreomacular traction here. So the plan for her was to have her undergo cataract surgery as well as a vitrectomy with a membrane peel, hoping to peel her ILM, do a fluid air exchange, and then leave her under some SF6. So here we go. So I'm calling this pinch me, I'm peeling. And this is a case I did with Dr. Sears. So the phaco component was done first. I decided to place ports ahead of time prior to Dr. Goshi doing the cataract surgery. Came in, cleared ports, and then started off with a hyaloid lift here.
So what are you thinking about during this PVD induction with that vitreomacular traction in the hole?
Yeah, so given the fact that she has this vitreomacular traction, we know that her vitreous, retina interface is probably abnormal in some way. I'm trying to be pretty gentle, and I'm trying to look over at the macula as I'm pulling and lifting the hyaloid to make sure if there's any, crazy traction going on there to kind of slow down. And I know we were previously talking about, how far we want to lift hyaloid. So in this case, given it's not a retinal detachment, I don't think we need to be as aggressive lifting here. So maybe just taking it a little bit, even not as far as the equator.
Hey, tell question. So there's, as Carolyn pointed out, we see VMT. Let's say there wasn't a hole, but it was just that first view of VMT. Where are you directing the cutter in terms of, like, which edge of the nerve are you lifting the hyaloid off of? She's coming here nicely on the nasal side. If the hyaloid's coming up, should she continue on that nasal side, or are you directing her to try to get it off the macular component differently or in a staged way? Can you talk us through how you're going to talk her through this?
Yeah, especially I think at the beginning of fellowship, I think I try and focus on just sort of keeping the fellow comfortable and safe. So in general, I start trying to lift the hyaloid either at 12 o'clock or 6 o'clock off the nerve. As it starts to pull up, I want them to be focused on sort of where they are, but I am, as the attending, often looking at the whole lot to make sure there's not a lot of traction there. I will, in general, not sort of peel across the macula as I'm sort of lifting, because more that if the patient moves, they're moving like right into your sort of instrument. If I feel like there's excessive traction sort of on the hole as I'm lifting, then I'll stop. I'll find where my gap was and go back down and lift. Adrian's obviously doing a beautiful job lifting here without steroid, but I think having steroid, especially at the beginning of fellowship, can be really helpful for these because then it can see, where your little ring is, where you can kind of go back in and regrab as you need to.
Carolyn, were you getting at being careful, not extending the hole and making it bigger with the VMT? Do you try to? I mean, in the good old days with 20 gauge, we used to like talk about using a pick to like dissect it off the macula. Is that something you do?
Yeah, I don't do a pick anymore, but similar to I was getting at what Kat basically answered was you're looking at the edge of that hole. And then in the chat too, and also what Kat mentioned, this is a case that I don't always use triessence, but this is a case where I would definitely use triessence because that vitreoretinal interface is so abnormal and the vitreous is probably pretty skitic. You might think you have a layer, but there's still some more. Where this just helps the fellow visualize and see where they're tugging.
Yeah, from when Prithvi and I were fellows, Glenn Jaffe would insist on doing this with a lighted pig, what we used to call the Black Max, and actually dissect through and just make sure that the VMT was released and that we actually dissected it off the fovea.
Yeah, the problem though is the picks these days I feel like aren't as sharp as the ones that
Mhm.
I had in fellowship. And so that's why
For
I don't
sure.
routinely use it very often
Yeah,
anymore.
I agree. Yeah, they're dull. Yeah, for sure.
But there still is a point, as you're all making, if there's tight adhesion and the preoperative OCT really helps you to sometimes just to get it off the fovea before you do the big lift, right? Like, so even if it means, a couple small maneuvers to get it off the macula and just at least the fovea, then you feel better about lifting all the way. Even if you kind of start at one point at the nasal edge of the nerve and then just try to go straight up, I think there's a risk of, just that coming off in a way that you don't quite recognize, and then you feel bad.
Yeah, it's less controlled.
Thank you for that.
I like that. I like the Prithvi feels bad.
I feel bad. It's mainly about that. A couple points.
Go ahead.
Adrian, which lens are you using here? A couple comments about maybe being under higher mag versus kind of your vitrectomy magnification. Any thoughts on that?
Yeah, we're still using the yellow lens here, but I just magged in with the scope.
Got it.
Yeah. So here I thought I got an edge, and we can see it lifting. Trying to be slow as I'm doing this and coming up. And I think there's a moment in time here soon where I feel like nasally, I don't need to go any higher. And I thought I saw an edge kind of temporally here that I wanted to extend a little bit more. And so trying to be very slow. But I don't know if I saw any moment in time where the vitreous kind of popped off the macula clearly.
I think that
did.
happened before surgery. Oh, did it?
Yeah,
You
go
saw it?
back.
I think Sumit's hallucinating, personally.
Usually.
He's got something on the screen.
Even there, I think it happened
Yeah.
earlier.
Wasn't it just right there?
Maybe.
I mean, you can't tell for sure, but
I think you should stop drinking.
Watch it again.
So it just
I think you
wanted to
should
be
start
like, it
drinking.
did. I saw it.
It's too early.
So yeah, not trying to be too aggressive here, and then slowly starting to do a peripheral shave. And again, not trying to be too aggressive. Don't feel like you need to get as much vitreous here as if it were, a retinal detachment case. Trying to avoid causing any breaks. And then once the shave is complete, we stained with ICG.
How long did you keep it down for?
Dr. Sears keeps it in for about 90 seconds or so. Oh.
Got excited there.
I know you're going to skip over the best part.
I know.
Prithvi,
So
back
what-
in your
what
day,
was-
would you peel? for that kind of VMT OCT? Would you peel ILM?
No, we would, they would, our mentors would hit us if we suggested it.
Exactly.
Yeah, no, so I think that, especially if there's no epiretinal membrane, we were using a version 1 OCT back then, so it was like very clunky. No clear epiretinal membrane, and if there's VMT with a small hole like that, I think that just hyaloid release, we would have been done. But that's
I still do that. I still like for these, I will just pop the hyaloid and put gas in
you
and
are
be done.
so old.
I
Jeez,
am
like
old.
there's
I
a
am.
modern era of retinal surgery, sir,
Yeah.
that we are trying to like teach people about.
I mean, you're not doing
But
like a flap on every single one of these. Why not?
Yeah, I should be stuffing it with amniotic membrane at the same
so
time. Make
Adrian,
sure,
so we'll
yeah.
ask you, did Dr. Sears and you discuss just releasing the traction and what was the conversation? And then tell us how you're planning to proceed with the ILM peel, because there's no epiretinal membrane that we saw on the OCT.
Correct. Yeah, we did talk about it. Initially, I think when he had signed the patient up for surgery, he talked about just doing the hyaloid lift. And then we discussed peeling and, how potentially there's a little bit of a decreased risk of coming back to surgery and a little bit of a higher hole closure. But overall, I think, visual acuity wise, these patients end up doing the same, especially when it's a small hole. And so in terms of starting the peel, I believe the Tano scrapers are on like back order right now, which is why I got to try pinching for the first time. I tried to start somewhere, kind of near the arcades, but not across a retinal vessel. And trying to, very gently grab as little of tissue as I can, not trying to grab the retina here. Here we're using the shark skin ILM forceps, and we will get started. So threw in some comedy here. This is from when Will Ferrell for the first time, or sorry, for the third time presented on SNL and was making fun of Pinch Me, I can't believe I'm doing this, even though he's done this so many times. For me, it was very much a different feeling. I can't believe I'm doing this for the first time. And, the ILM staring at me like, pinch me, where? So I decided to start kind of superiorly
So
here.
what lens are you using?
We're on the green lens
We're on the
here.
green lens.
Yeah.
Okay, got it.
We're still on the green lens here, or on the green lens instead of the yellow lens. But so we started off right over here, maybe a little bit of a stronger touchdown, and then decided to kind of continue to propagate that.
Wait, you gotta
inferiorly.
go. Wait, hold on. You
You
gotta
gotta
go
go
back
back.
to that. Yeah, that was yeah, you gotta go back. You gotta go back.
You're so
Go back.
close.
Go back. Yeah,
Oh
go.
yeah.
We're good.
You wanted to see the Will Ferrell again? Is that
Well, no, I think it's like I think just pause there. I think this is so look great.
Yeah.
so
Maybe,
Yeah.
maybe like talk through a couple of things, and maybe mentors can
yeah.
talk through here. I mean, I would say that I think sometimes having the forceps a little more closed before you're going down would be something I would recommend. Because there's this forward motion of closing. That's something that happens to all of us. And you probably noticed it when you did it, Adrian, just like your hand moves forward. It's natural. So I'm just curious, like we got a bunch of mentors here. A lot of people walk through people through pinch and peels. I'm curious what you think.
Sumit, you start.
I'll go
Yeah.
first. Yeah. So, I think it's misnamed. I think it should be pinch then peel. So what I always say is slow down, and really slow down. Go down, as you come down with like you said, the tips almost touching together. Try to grab just a little bit and then release it. And what I'm actually trying to see is a little bit of that ILM kind of bunching up. And that is when I then want to go, and I'm going to stay right there. When I say go down, grab, and release, I emphasize you really want to stay right there, look at what you did, and then grab that a little bit more superficial, that pinched up ILM. And I find that that's the most atraumatic way for me with fellows to teach it, at least in the beginning. But what I typically see is what you did, which is you go down, you grab, and you move really quickly. And that's not what you want to do. You want to really, really slow down, just very slowly, come very close, tips almost touching. And then as you finally close the forceps, that little extra forward motion will pinch the ILM for you, release it, and then go ahead and grab it again.
Carolyn, give us a pearl.
Well, I remember the first peel I did was with Hubschman, and he said basically what Sumit said. He's like, close the forceps. And he's like, and just touch the retina. And so I did that. And he's like, okay, good, let's switch. And that was like my first time.
So that was touch, then
Yes.
peel. That's not pinch and
Yeah,
peel. That's
right.
touch and
And
Touch
peel.
then
and
the
don't
second,
peel.
then
Yeah.
the second case, it was okay, you proved that you can touch it and not go through the retina. Now you touch it, and it's the same thing. He's like, okay, same thing. You're gonna touch it, but just like keep it barely open and then pinch. You're gonna see that little, and he didn't never stain. He was anti-staining for everything. He's like, you should be able to see the membrane and see the retina. And half the time, I'm like, I don't know what I'm seeing. Um, and same thing, you see that little wrinkle, and then that's what you're gonna pinch and you're gonna peel that. So same, nothing earth shattering. I do think, the left eye is the hard eye to start off for our right-handed dominant fellows because you're like reaching across a little bit. So if I can cherry pick cases, I try to get the right ERM or macular hole for their first one, just because it's like ergonomically a little bit easier. Also outside the scope, like make sure you have good support. So if the wrist rest is too low, or even if it's not too low, putting like another towel underneath is good. And then just make sure all your big muscles are relaxed. So you don't notice that your like shoulders are hunched. You're like so nervous. Really get everything nice and relaxed. He sometimes would have us just like go for a walk around the OR for a little bit and then sit back down. And if he saw you shaking a lot, he'd be like, get out, go for a walk, take a deep breath, and then do it again.
We offer decaf lattes in our ORs to our fellows and during
Only
the
caffeinated
cases.
here.
You can do some box breathing.
Yeah. Okay.
Kat,
So,
you got it. Kat, you anything else to add?
wait, before you add, if you can just play a little bit, Adrian, I'll tell you to stop it in just like 2 seconds. But you go from there and stop right there.
So this is what freaked me out.
Yeah. So, Kat, any thoughts on cleaning the tip?
I love Adrian. I think Adrian's doing a beautiful
She's doing a
job
great
on this
job. She's doing
peel.
a great job.
Doing a great job on this peel. But the flicking does make me nervous at the beginning. I'm
Every
a
time.
flicker. I think I flick probably more than other people do. But it's more that I try and get like a farther away from the retina, and I'm not flicking as much as I put my light pipe in between my two forceps, and then I just gently move it. And I would say towards the beginning of fellowship, I would much rather the fellow sort of just come out of the eye and I'll be ready with my instrument wipe than doing sort of any flicking. But I think Adrian was just so excited to be able to peel. She's
Yeah.
like, got to keep peeling, otherwise John's going to take over the case.
Adrian,
So got to keep going.
this is all great. And then, I think if you're using a flat contact lens, your field of view is going to be different than your green lens. So, here you will see this. If, I was doing that same move with a flat contact, I'm probably off my, out of the field. And then suddenly there's something going on that I'm not going to see. So as long as you can see your instruments and kind of bring them up a little bit, and then you go back down again. And that's part of the learning right now, kind of moving away, coming back, moving away, coming back. That's also building muscle memory, like as you're going. So
So
yes,
that all
great,
said, this
great
is a
start. Keep
great this
going.
is a great pinch and
Absolutely.
peel because
Yep.
of what you have here is you have so much area to go. I mean, I think this is nuance, right? The things I think we're talking about are nuance of trying to make sure that technique is solid for the 100th case. Go for it.
Keep
100%.
keep showing.
Yeah, so then just started to kind of try to move this and give myself a little bit more of a working edge. Now I have my tips kind of parallel to the new edge, and I'm trying to just walk across it. And so trying to pick up this edge of ILM here a little bit more gently this time, and then trying to walk down and give myself more of a working room. Unfortunately, here is when I wanted to reset just because, the view is getting hazy. The ILM lifted, but now I realize I have to still peel. So trying to refocus, get a clearer view, and restart now, working my way around. And Dr. Sears kind of recommended doing almost like a capsulorhexis here with the ILM. So I'm trying to kind of make a circle slowly.
Wow.
Oh, Adrian, that's perfect.
Nice.
That's
Beautiful.
Good
amazing.
job.
You're doing
That's
great.
great. That's great.
And then
Just don't
again,
do that.
smashing instruments. And then trying to grab this is a little bit more redundancy here. But
So
Gotcha.
I think
ended
you
up
did
making
something
it
there
circle.
that I think is a pro move.
Mhm.
You had the flap, it folded over a little bit, and then instead of grabbing
Mhm.
like that free edge, you kind of grabbed kind of the sandwich part of the flap as it came over. It's a little thicker. It's not floppy, and it's at the point of adherence. And I think that's important as well because
Yep.
it's sitting up there just folded, kind of grabbing that as it is. And I'd also say like, fixing the view, readjusting, coming out of the eye for Cat to like wipe your instrument and, like that type of thing. It buys you like a second or two of like, resetting. Like it calms you down a little bit, especially if it was like not as, smooth as you're showing us. It is like these hard peels, just kind of take a second and then, just it buys you time to reset. And then you kind of lose a little bit of that nervousness and maybe you can start to think about, oh, I'm going to go here next. So like don't underestimate the, oh, can we like fix the cornea a little bit like as a move, or Cat, can you wipe my instrument for me, which I prefer.
That's great advice. Yeah, so then just grab that membrane. We made sure that there were no breaks in the periphery. Then we did a fluid air exchange. And then filled the eye with 20% SF6 and made sure that all the sclerotomies were closed. And then we did face down positioning just for 24 hours until their post-op day one. And unfortunately, this was just done a week ago, so they've only had a post-op week one appointment. Their vision was still hand motion from the gas, but through the gas, apparently, I don't know how the technicians did this, but reading, they're able to read 20/25, but I don't know what that means.
They are
So,
cheating out of the other eye. That's
exactly
Fellow
right.
eye.
But yeah,
Hey,
um,
great job.
thanks
Great
for all the
feats.
advice.
Well done.
So, one of the questions that came up, Adrian, was this your first peel when you did this pinch and peel that came up in the chat?
I had done probably maybe like two peels with Dr. Talcott where she had started an edge for me and then I had peeled, but this was my first kind of full start to finish.
Nice. Great job. Well done.
2 thumbs up. Our fourth and final fellow for this evening is Joanna Ando. Joanna went to Yale for medical school and the Johns Hopkins Wilmer Institute for her residency, and is going to show us a case of a retinal detachment that she repaired.
Thank you, Dr. Mruthyunjaya, and congratulations everyone on the presentations. It's been amazing so far. So happy to end our presentation. Please let me know if you can see my slides or the
Presenter view.
That's awesome.
Okay, let me swap display. Okay, how about that?
Good.
Okay, cool. All right, yeah. So again, on the similar theme, just to set the scene, it was my first week on call. Everyone was gone at ASRS, so I was holding down the fort as the newbies. My black cloud energy followed me from residency, but yeah, I just wanted to create like a pictorial depiction of what was a fun week with Dr. Leung. So for this patient, they ended up coming in clinic. They were a referral from outside, 52-year-old software engineer, had blurry vision for about a week. He had been evaluated for cataract surgery about a month ago. So for him, he thought this blurry vision was just a part of the sequelae of his worsening cataract. But he lost central vision about 6 days ago. I mentioned that cataract surgery that was planned. And he was myopic, but he didn't know his particular prescription. Past medical history, nothing too crazy, just some asthma, hypertension, and uncorrelative medications, no allergies. Initial exam, so he was 20/50 in the right eye, and his good eye, he was 20/30. Pressure was normal. He was phakic in both eyes. He did have a notable PVD in that right eye. This is a wide field pseudo color fundus photograph of the right eye. And as you can note, he had a pretty substantial retinal detachment. The clock hours, it spanned from around 6:30 to like 11:30, 12. MAC was off. And although you can't see there were some inferior tears, some inferior temporal tears, but the most notable tears, I remember showing Dr. Mruthyunjaya in clinic, there were about, I'd say like 5 or 6 just in a series. I remember us talking as if it was almost like an impending GRT. It's just all in a row. Luckily, his left eye looked good, and he did have a PVD in that eye. This was the OCT retina. So as you can see, the macula was involved as well as the fovea, and left eye looked normal. So I just wanted to formulate this patient. So 52-year-old myopic phakic male with a PVD coming in with about 6 to 7 days of vision loss, found to have a MAC-off rhegmatized retinal detachment. So I wanted to pause and at least discuss with the group, what would the surgical approach be? At this point, we were thinking, well, I discussed this with Dr. Leung, who was the attending on call, because you could, at some point, we were discussing possibly pneumatic, although there were a lot of tears. He did have some inferior pathology, and he was phakic. And there was thoughts about a primary, just a primary vit. But just given the number of tears he had and how much they were in a series, there was a concern for some abnormal vitreoretinal interface that could benefit from a buckle. And then, of course, there was the discussion about a primary buckle versus a vit buckle. So happy to pause if people have thoughts, or I can fast forward to what we ended up doing.
Yeah, I think this is all institution dependent, right? You could make an argument for each of these things, and it's what's your local place, the going speed of it, getting into the operating room, those sort of things. I'd say here in Cleveland at Cole, this is in a myope that's young. You're not sure if they're, I would question whether or not they truly have a full PVD. This is a buckle vit.
And that's what we ended up doing. So 25 gauge, we ended up going to 42 band, and we did 14% C3F8. So I'm going to go along with the video. Everyone can see it okay?
Yes.
Okay. So it started after peritomy, but we ended up doing a 360 peritomy. And this is the part in which we are just dissecting the tenons to make sure that we have ample space to assess the quality of the sclera before we isolate the intraocular muscles. And we did this under the scope. This was actually the first buckle I'd done under the scope. Most of the time I'd done it without the scope, without loops, but I actually enjoyed doing it just from a point of visualization, which I think is a big theme throughout like an early VR fellow experience. But I think especially with scleral passes, and I'll slow this down here, but at this point, so we ended up using 5-O-mersaline double-armed for our scleral passes, and we pre-placed the sutures prior to the buckle placement. So we, like I mentioned, we went with the 42 band, and we wanted a pretty significant imbrication. So we ended up measuring 3.5 millimeters from the muscle insertion, and Dr. Leung may be on the call, and I believe 5 millimeters from that second measurement. So in this case, with the double-armed, for certain maneuvers, it ended up being kind of a forehand, pretty straightforward pass. And I think it was nice, especially under the scope, like being able to visualize the needle, like particularly going underneath the episcleral vessels. So I think there was that assurance in terms of reducing the risk of perforation. For these,
one of the challenges with doing it under the scope, you're saying all the advantages, but one of the disadvantages is sometimes you don't carry the pass as long as you would if you're outside the scope. There's a risk that it's a little shorter, which might not give as much contact. So it is important to kind of I have fellows check the like the strength of the needle pass with every pass, because you think you're going long, like a long pass, but it's just shorter because of the field of view. But these look good.
Yeah, so so from there we ended up threading the 42 band underneath the muscles and then underneath the mersaline before tying down the buckle with the mersaline. And so I think at this point, I guess this was also my first time. We ended up having a series of these cases, but this is my first time using mersaline. Prior to that, I think with nylon, I could tell it had a different type of memory, and I think I was more worried sometimes about snapping nylon versus mersaline. So this had a little bit more of that, I think it was able to take on a little bit more tensile strength. Maybe that's my subjective experience, but that was one thing I noticed with using this versus nylon sutures. And I haven't particularly used belt loops, but I've been told they can be faster too. So I think the benefits, kind of the benefit analysis of Merceline versus nylon versus belt loops, still learning those differences as well. And then we ended up placing the 70 Watsky sleeve superior nasally. And at this point, we're doing trocar placement. And I've been working on my trocar placement kind of post conjunctival peritomy, just because sometimes I think it depends on the patient's anatomy too. Whether it's thin sclera and may not, even though I try to bevel, sometimes the trocars will start coming out like in the middle of the surgery. So that's one thing I've been trying to be more conscious about, particularly with trocar placement after a conj peritomy. But we ended up placing them more around like 9 and 3 to have better access for the temporal tears. So at this point, we did know that the patient had a PVD. I was trying to review my video because I didn't necessarily see a specific moment in which I was trying to induce a PVD. From what I remember intra-op, there was a pretty discrete shadow in terms of the outline of the hyaloid that was within the mid-periphery. So I do remember, at least intra-op, we were pretty confident there was a PVD. So we didn't end up using triamcinolone. But this is the corvid, and during this time, I could notice that the retina was already becoming a little bit more kind of bullous once we were able to relieve the traction near those temporal tears. This is just us adjusting the buccal to create a better imbrication.
So it wasn't high enough initially?
Yeah. So, and Dr. Leung, maybe you can comment on this too. Intra-op, we were actually pretty surprised. We thought the buccal was tight enough, but we weren't seeing an imbrication. So we did end up adjusting it a couple times intraoperatively.
Yeah, it just didn't. When we looked at it, I wanted to see more buccal height, so we tightened a little bit.
And then at this point, we end up using PFO to kind of flatten the retina, and we put enough PFO up to the breaks. Luckily, kind of there was a tangential line between all the breaks. And at this point, I'm amputating some of these horseshoe tears just prior to preparing for the diathermy. But I think in this case, some of the challenge, especially having done a buccal, was realizing that cornea is time. And as I was trying to get more efficient, I was also trying to see if we didn't have to debride the epithelium just from a visualization standpoint. So that's us adjusting it. And then this is us eventually deciding to debride the epithelium, despite our best efforts with the OptiView. And then at this point, this is the peripheral shave. And then we end up doing a fluid air exchange with the PFO. So at this point, I was draining from the breaks, and then I think I go back in here actually. Yeah. So at this point, I was draining from the breaks and then draining the PFO once I was able to drain the fluid from the level of the breaks. Went too far back. And then end up doing the endo laser under air, which I think for me, I'm still working on visualization, especially under air versus under fluid.
What were some of the challenges that you were like working around?
Yeah, I think it was a lot of times it was the reflection of the light. I felt that under air you get more scattering of the light, and so for me, trying to coordinate with my light pipe just to make sure that I felt like I was within this. And also, as I was following the curvature of the globe, I felt like it was taking pretty well, say, compared to fluid, especially since those breaks around there wasn't much fluid and it was dry. But I was also trying to be conscious of not creating like a very white or intense burn.
Was this the lighted laser or was this the non-lighted laser?
This was the lighted laser, if I'm correct.
Which sometimes, like if you have the light pipe and the lighted laser, like sometimes it can throw some like extra glare at you. So something to keep
Okay.
in mind. And
Okay.
it's fine either way. It's just knowing that if you really have like some glare issues, that it could be that it's too much light, or you have to move the primary light back a little bit. But the lighted laser can be helpful.
Mhm.
With your ports almost 180, when you're doing a laser with the curved, you're going to contort the eye a fair amount, especially under
Mhm.
air. So just a little movement of your hand is going to make it, you're going to lose focus. So this is
Yeah.
not uncommon. So just one of the things to remember is that, you got to keep your hands a little steadier. I like doing
Mhm.
this under perfluoron at this point,
Mhm.
and then, as I think someone mentioned in the comments, and then coming back to air, but you can certainly do it under air. It's certainly very reasonable to do so. And, it's just a yet another skill set you're learning right now, sooner rather
So,
than later.
so some at like 3 and 9 o'clock, like is you need to be able to get access, but what's your thought about moving one up a little bit or the other down? What do you think about 3 and 9 for port placement?
Yeah, I know. I like to look at where the brakes are preoperatively, and if I know there's going to be one right below one of the ports, or that's my only brake, I'll likely adjust positioning a little bit. I tend not to do 3 and 9. I tend to like them a little bit higher and a little bit lower on the other side. I think it gives you a little bit more access, but and you avoid the nose that way. But if it's a low nasal bridge, you can get away with it.
Yeah, I think one of the risks is that you could be pushing in a little bit, Joanna, and
Mhm.
if they're exactly opposite to each other, and suddenly like your view goes in and out, you're like, why is that happening? And it could be just because you're indenting a little bit.
Mhm.
Did you guys decide to do like laser across the buckle, like with these multiple breaks, like any extra laser, or did you just laser the breaks?
Yeah, so the patient didn't have any other pathology, including lattice, like anywhere else from the brakes. So we ended up just lasering the brakes.
I think that's reasonable. You have a buckle as well, which is
Mhm.
helpful.
Yeah, there were
Yeah.
so many breaks that it ended up being most of that temporal side anyway.
It's fair
Yeah.
enough.
Makes
Yeah.
sense. Yeah.
And then the rest of this is just closing, which was uneventful in that case.
Great.
So yeah, so from this standpoint, we've had a couple post-op visits. The most recent one was post-op week 2. He was count fingers because of the bubble, but overall he was attached, at least on the OCT that we got. So yeah, I'm looking forward to seeing him like post-op week 4 or 5 to see how he's doing. Yeah.
Very
Nice
nice.
work. Great
Yeah.
work. Great start.
Good. Kind of walked us through like your steps, which I think is really important as you're sorting through this. Good job.
Yeah.
Thank you.
I think this is a great start to Cobra.
Got some peels, got a detachment, diagnostic vitrectomy, and a future enucleated eye that Prithvi does. We should always have that as one of the first things you get to do
It's
during.
motivating,
We
if
we were
nothing
just
else.
missing the 2 a.m. bilateral endophthalmitis.
Yeah, that's right. That's a Cobra special. That's a
Stanford special.
great
Coming.
start. I'm
Mhm.
very proud. I mean, I think great job of the mentors here, and wonderful work, obviously, by the fellows in putting these things together. I think we're excited for another year of Cobra.
We want to thank Bausch& Lomb for their continued sponsorship, and to the team at iVista for putting all this together. And Sunil, when is our next Cobra event?
As you can see here, Prithvi, it's Cobra After Dark. We're going to be at AAO in New Orleans, and we're going to be at the Republic, NOLA. Please come. This is going to be a great time. We have our second year fellows present in front of everybody. We have a really lively experience here, and everyone is invited. It's a free event, and usually a really great time to connect and to get
Like
to
very
meet some
close to
people.
the convention center, I think, like a couple blocks away, so should be easy to get to.
Aren't you staying there that night? Also, we putting up a bed there for you so you can hang out there
Basically,
afterwards?
like for a whole week before too. It's going to be great.
Excellent. Well, please come cobrasurgicalrounds.com to register. It's supported by Bausch, and it should be a fantastic time. All right.
Very good.
Good
All right.
start. Let's
have a good
have a
night,
great night.
everyone.
Thanks for coming in, and
Good job
we'll
to our
see you guys
fellows.
in New Orleans. Nice job. I can't believe our next one's going to be just the live event. That's awesome.
AO is early this year.
Yeah.
Yeah, that's right.